Now I'll be discussing an ECG with atrial flutter, and the mechanism of atrial flutter will also be discussed. Even though in the ECG which I am going to present first, recognition of atrial flutter will be very easy, but do not think that it is always so easy. Atrial flutter is an arrhythmia which can be missed on the ECG, which I'll come to during the discussion. Anyone with a basic knowledge of ECG can easily recognize the flutter waves, sawtooth shaped flutter waves in this ECG. So no points are scored for diagnosing atrial flutter in this ECG. There are some other things to be thought of. Here you have two RR intervals and there are three flutter waves in between. But this is not 3:1 conduction, but 4:1 conduction, because you see the interval between these two P waves and the interval between these two flutter waves, not P waves. So this is double. So naturally there is one flutter wave hidden within the QRS. So if you count that, that will be 4:1 flutter. Otherwise you have to say the ratio by calculating the RR interval and the FF interval, and comparing these two you should say the ratio. Similarly, this is 2:1 conduction, because there is one flutter wave here and another will be there, and this rate is around 150 per minute, and flutter rate is usually around 300 per minute. So this is 2:1 conduction, this is 4:1 conduction, this is again 2:1 conduction. Here you have 3:1 conduction. There are two flutter waves in between and there will be one on this QRS also. So there is a variation in flutter conduction in this case. Then it is easy to recognize the flutter waves because you will see the flutter waves between the RR intervals. Suppose it is 1:1 conduction, it is almost impossible to recognize flutter, because for every flutter wave there will be a QRS. Then the rate is also going to be very high, 300 per minute. But typically for atrial flutter there will be at least 2:1 block and the rate will be 150. So the dictum is that whenever you see a tachycardia, a narrow QRS tachycardia at 150 per minute, think of atrial flutter, because atrial flutter typical rate is 300 flutter rate, that is atrial rate. So when there is 2:1 conduction, you will have 150 heart rate. So when you see an ECG thought to be of sinus tachycardia or supraventricular tachycardia of other types, but the rate is 150, always think of atrial flutter. Then in this ECG there are other findings also. There's a tall QRS in lateral leads. Here also QRS is tall and deep as in V1, indicating left ventricular hypertrophy. You know that atrial flutter is a macro-reentrant arrhythmia. Macro-reentrant arrhythmias are highly sensitive to cardioversion. Atrial flutter can be cardioverted by maybe just 25 joules or even lesser, because when it is a large circuit, if you can cut any portion of the circuit, you can get a cardioversion. Unlike in atrial fibrillation, where there are multiple reentrant circuits and you need higher energies, at least 100 joules will be required for cardioverting atrial fibrillation. Atrial fibrillation is more resistant to cardioversion than atrial flutter. I already mentioned that atrial flutter is a macro-reentrant arrhythmia. These are the types of common atrial flutter circuits. In case of flutter, the commonest region of slow conduction is the isthmus, cavo-tricuspid isthmus. That's a region of slow conduction. That is, this is cavo, this is tricuspid. So in this region, this is the region where there is slow conduction, and that's also the region targeted for ablation when atrial flutter is ablated. And there are two types of circuits. One is a counterclockwise circuit, and this is a clockwise circuit. So you recognize these two in the ECG by looking at the flutter waves. If the negative component, that is, the flutter waves are differentiated by looking at the less sharp region of the wave. In the sawtooth itself, one region will be slightly less sharp. So the direction of the less sharp wave is taken as the direction of the flutter. So if it is negative, it will be counterclockwise flutter. That is away from the inferior leads. Negative in inferior leads. The ECG which we have just seen shows like that. The rounded portion is negative, so that it is a counterclockwise flutter. If it's the other way around, it is clockwise flutter circuit. So ablation is targeted in this region, cavo-tricuspid isthmus. Correspondingly, there is a mitral isthmus on the left side. So in case of left atrial flutter, it could be isthmus of the mitral valve. That will be on the lateral aspect. So then there is another thing. Flutter need not always be due to cavo-tricuspid isthmus related re-entry. It can also be scar related. Suppose there is a scar of previous congenital heart disease surgery, then flutter circuit can occur there also. That is different from the usual cavo-tricuspid isthmus dependent flutter. This is a case of atrial flutter in a patient with mitral stenosis and naturally left atrial enlargement. The features are different here, but this is also a negative here. And I would like to highlight certain things. That is, you look at lead V2. In V1, it is usual typical sawtooth shaped waves. But in V2, it is not like that. V2, at one look, it will appear like a atrial tachycardia. You are not seeing something like a flutter wave. So you may think that this is an atrial tachycardia rather than atrial flutter. And in other leads, the waves are hardly seen. Here, small flutter waves, or you would think it is P wave only and not flutter wave. Here, almost nothing is seen. So this highlights the importance of checking multiple leads in arrhythmia analysis. Suppose this is the lead being monitored, you might think it is atrial fibrillation. Especially this is a patient with mitral stenosis, you think of atrial fibrillation. And the RR intervals are somewhat irregular also. But the irregularity is because of varying conduction of the flutter waves into the ventricles. So the cutoff is that when there is an atrial tachycardia, usually the rate is below 250 per minute. Here the rate is 300 or above 300. You can see here it is almost 4 divisions. So it will be above 300. Usually it will be below 250 for atrial tachycardia. So this is also an atrial flutter in a specific subset in a patient with mitral stenosis. This also you will think it is atrial fibrillation in this lead. Here also it is more or less like atrial fibrillation, but flutter waves are seen sometimes. V1 and lead 3 and lead 2 shows, and AVL also shows, AVF also shows good flutter waves. So that's the importance of looking at multiple leads. For example, in the ICU, when you monitor a patient, you may be seeing only one lead. But most of the monitors have facility for multi-lead recording. So you should enable multi-lead recording, rhythm recording, when you have an arrhythmia. This is another ECG with atrial flutter, but can be easily mistaken. See, you can't see any flutter waves in this lead. You can see flutter waves here if your mind knows that this is atrial flutter. Otherwise, this may be taken as a P wave and you will think that this is sinus tachycardia at a rate about 200 or so. And this is in an infant, neonatal atrial flutter. Here the flutter rate is around 400 per minute. Unlike in the adult, in neonates the rate will be more. The flutter rate is around 400 per minute and you have ventricular rate around 200 per minute. That is the situation in neonatal atrial flutter. In this ECG, if you look at this region, you can recognize flutter, but you may miss it as well. When there is a doubt, one simple procedure you can do is give a carotid sinus massage. Not in the infant, it may not be easy, but in an adult or older patients, if you give carotid sinus massage, the flutter conduction ratio will change. That is, there will be more blocks and it will either become 4:1 or become irregular 4:2 as we saw in the earlier ECGs. Then it will be easier to recognize the flutter waves. This type of flutter with 2:1 conduction is very often misdiagnosed as just supraventricular tachycardia or sinus tachycardia. Another importance in a neonatal atrial flutter is that when the heart rate goes up, fetal heart rate goes up, it may be mistaken for just fetal distress and not a fetal arrhythmia. So pregnancy may be terminated and baby may be delivered fast without actually being there a fetal distress. So that's the importance of atrial flutter. But it is not possible or rather easy to get a fetal ECG. You have to go for scalp recording in labor, and there are other techniques known as fetal magnetocardiography which can recognize arrhythmias in the fetus. Often in the fetus you will have to go for echocardiogram, fetal echocardiogram, which will show fetal arrhythmias. There will be difference in the atrial contraction and ventricular contraction, but those are all rather difficult methods. This is not a fetal ECG, it's a neonatal ECG taken after the baby was born. Even for recording neonatal ECGs, there are difficulties. The chest leads you cannot just place using the suction cups. It will be almost like doing a skin biopsy. You will see a red spot over there and there won't be enough space for keeping all the electrodes on the chest. What is usually done is a small, either you can apply a little jelly on the ECG electrode tip, and there are small electrodes available also which can be pasted on the chest and taken. That's how fetal ECGs are, not fetal, neonatal ECGs are taken. It requires a little more technique, and if the child is restless, you may have to sedate or wait for natural sleep.